Welcome to the other side of Letby. In episode 69, we're going to look at what people like to call nowadays misinformation. And the people who are most fond of using this term misinformation are very often people who generate a lot of misinformation. As far as I'm concerned, there's no such thing as misinformation. There's information that's true and there's information that's false. But there's nothing mis about it. But we're going to listen to this podcast channel, Courtroom Scene 2, that is a Letby channel. And I'm going to use medical science to explain to you just how much misinformation this guy is pumping out. And I think we should consider this as a kind of thought experiment, that if this guy was in the court, as he says he was, that's the whole premise of his channel. He was in the court during the whole trial every day, and that's what gives him the authority to talk about Lucy Letby. That anything I say, because I wasn't at the trial, is misinformation, according to him. Now, the purpose of this episode, which is a recent episode of this podcast on YouTube, is to show, as far as he's concerned, the host of this podcast, that Professor Xu Li, during the press conference, left out crucial medical information. Now, I want you to consider the fact, not an appeal to authority, but a probability. What is the probability that Big Tam on Facebook, like we have here in this YouTube channel, knows more about neonatal medicine than the 14 people who compiled the report? I'll leave you to work out the odds, but I would say they're pretty low. So we'll just go through his podcast first, and you can suffer your way through it like I did, so that you can hear just how misguided this guy is, and that he could be a decent proxy for any member on the Letby jury. So buckle up, listen to it, and then we'll point out all the feelings.
In August 2023, former neonatal nurse Lucy Letby was convicted at Manchester Crown Court on 7 counts of murder and 7 counts of attempted murder concerning patients under her care. A year later, she was subsequently convicted on a further count of attempted murder in relation to a case on the original indictment. She remains the UK's most prolific child serial killer in modern British history. However, recently a press conference took place in London, arranged pro bono by the PR agency Maltin and attended by the MP David Davis, Mark MacDonald, as well as others, and Dr. Xu Li, who presented the press conference with his new findings in relation to Lucy Letby's convictions, claiming they found no evidence of murder or attempted murder. What also appeared after the press conference was a report written by a panel of 14 experts, again in relation to some of the babies in this case. Now, this video seeks to explore what was actually withheld from the public during this press conference in relation to Lucy Letby's original trial.
Now, here we have Big Tam on Facebook going to put us all right about what Professor Xu Li missed.
This has been made possible by the purchasing of court transcripts concerning Lucy Letby's original trial. So let's start at the beginning with the first child on this indictment, Baby A, also referred to as Baby 1 during the press conference, and Dr. Xu Li's new explanation as to why Baby A may have died. Take a listen to the following.
So we're going to give you the highlights of what happened, talk about what the allegations were in the conviction, and what did the panel find? So Baby 1 was a case of air embolism. This was a preterm baby, twin 2 infant, who was born by emergency cesarean section. And he was well until the 2nd day of life, when he suddenly collapsed and had skin discoloration with blotchy patches of brighter pink on a bluey grey background. And he did not respond to resuscitation. The allegation was that Baby 1 died from injection of air into the intravenous line, causing air embolism and resulting in collapse, patchy discoloration of the skin, and eventually death. To begin, I will give you a little bit of background on the publications of air embolism. The prosecution in part based their allegation on a paper that I had written in 1989, where I described all 57 cases that had been published to that point in time. And it showed that the babies would present with a certain number of symptoms or signs, and also that about 10% of them had skin discolorations of different kinds. At that time, I did not distinguish between arterial and venous air embolism. And in this particular case, the allegation is that she injected air into the venous system, into the veins. So there's a difference between arterial and venous, because the arteries carry blood to the body to supply the organs and the skin, whereas the veins actually carry blood away from the organs or the skin to the heart and to the lungs. And in the new paper that I had published in December of 2024 in the American Journal of Perinatology, a copy of which will be in the summary report that you will receive, we actually separated the cases with arterial venous air embolism from the cases with venous air embolism. And what we found was that in the cases where air was injected into the veins, there were no cases of patchy skin discolorations ever described in the literature. So the notion that these babies can be diagnosed with air embolism because they collapsed and had these skin discolorations has no evidence in fact. All right? None of this actually has ever been described. If this is true, it would be the first case ever described, but it's never been. And there's a reason for that. The reason is that in the arterial system, when you inject air into the arterial system, it goes directly to the skin or the blood vessels or to the organs. Whereas in the venous system, it has to go to the lungs first. And the lungs has a complex bed of very small blood vessels that filters out all the air bubbles if they come through, so that they don't actually get to the arterial system. Now, in newborn babies, there's a hole called the foramen ovale in the heart, which can allow the blood to actually move over to the arterial system. But it has to go against pressure, because the pressure in the arterial system is higher than in the venous. And so what we found in the literature was that there were no cases that have been described where, in fact, these skin rashes have occurred. So let's do away with that theory. All right. The notion that these cases are air embolism because they collapsed and because there were skin rashes has no basis in evidence. Okay. Let's be very clear about that. Now, so what can be the possible causes then? Why did this baby suddenly collapse? So we went into the history of this baby to see what actually happened. So in this baby, the mother had antiphospholipid syndrome, which is a condition in which the immune system mistakenly creates antibodies to attack tissues in the own body.
Now, by the body in the body, Professor Lee is referring to the mother because she is the one with the disease.
The antibodies can pass through the placenta to the neonate.
The important word here is can pass.
And lead to thromboembolism, which means clotting in the baby. Particularly happens if there is concurrent infection.
Now, that means that the antibodies, if they pass, are particularly dangerous when there is a predisposition by infection and other causes to make them work to create clots inside the baby.
Now, post-mortem of baby 1 showed that there was a recent non-occluding thrombus in the liver.
So here we have new information, not held back information, new information, that there was a pathological finding of a non-occluding clot in the portal vein in the liver of baby A.
Which means that, in fact, there was a thrombotic event that happened in this baby after the baby was born. On the day of the collapse, the baby's IV tissued at 1600 hours. Tissued meaning that the IV that was supposed to be in the vein somehow penetrated the vein and came out into the tissues.
Now, as we remember, that may have been before 4 o'clock. We don't know. And it was a peripheral line. We don't know what the fluids were going into it before it tissued. But the nurse clearly admitted, in evidence, one of the nurses clearly admitted that it could have been before 4 o'clock. So it was 4 o'clock when she recorded it, but it could have tissued before that. So there was no fluids going into the baby, a minimum length of time of 4 hours, but likely more than that.
And so the infusion was not going into the circulation, was going into tissues. And so the area was getting swollen because the infusion was coming out. And so because of this, they removed the IV and replaced it with an umbilical venous catheter. But the first insertion was malpositioned, and so they had to replace it again.
And there were actually 3 attempts, and the junior doctor who was there asked for senior assistance, but no one came to help him. And the malpositioned third attempt, umbilical venous catheter, was then left in place for a period of time between 1 and 8 p.m., 1 p.m. and 8 p.m., a possibility of 7 hours. It was left in there without any fluids running into it at all.
Later on, a long peripheral line was then inserted at about 1900 hours.
So this is the second line, the peripheral line, which also stayed in place in a less than ideal position for another hour without fluids running in it.
Now, they then took an X-ray, etc., to make sure it was in the right position, and eventually the infusion was restarted. But an infusion was restarted at 2000 hours. So there was a period of up to 4 hours when these lines were in, but there was no infusion. Now, here's the problem. Even in a baby without any problems, we avoid putting lines in without infusion. Because if you do that, clots can form on these lines. In this case, the baby actually predisposes to clot formation because of the antiphospholipid syndrome.
Now, he's already mentioned sepsis as another risk, and we know that the mother had cholestasis. And that means that there's going to be an impact of that. And I'll explain that when we get to it.
And therefore, to have lines in there for 4 hours without infusion is a risk. All right. Now, what had happened was that minutes after the infusion was restarted at 2000 hours, baby 1 collapsed.
And that's what we call the proximity event, or a proximity event in a causal chain. Now, it's really strange that Lucy Letby only has to be present when a proximity event occurs, but this proximity event, which is highly relevant, is not considered at all as the likely cause of the problem.
It is most likely that there was a thrombus that formed on the tip of the catheter that then dislodged when the infusion was started, and it migrated to an artery supplying the brainstem, causing sudden collapse and inability to resuscitate the infant. It is also possible that baby 1 had placental fetal vascular malperfusion. So what's that? That's a condition in which the fetal villi in the placenta present small thrombi that can travel to and occlude small blood vessels in major organs like the heart, brain, and liver. And if a small thrombi lands in an artery supplying a critical structure like the brainstem, it can also cause sudden death, and they are very hard to find on post-mortem. Because these vessels supplying these critical areas of the brain or the heart are very tiny. And so all you need is a small thrombus to occlude it. When you're doing a post-mortem, you're doing cuts to see whether you see anything. And you have to actually cut exactly where that thrombus is in order to identify it. So just because a post-mortem doesn't identify it doesn't mean it isn't there, right? And in the second condition, which is fetal vascular malperfusion, these collapses can occur 1 to 2 days after birth. So one of these 2 causes probably caused it, and we think it's the first one because of the temporal relationship with the lines that were inserted, the predisposition to formation of clots on these lines if you don't infuse it, and then the occurrence of the collapse just minutes after the line was infused.
It's very important at this stage that we understand that the professor is saying if and possible, and that he is really focusing on the central venous line that's malpositioned, because it is going to be, or the tip of it is going to be, in the location where the occlusion occurred. So again, we have another proximity event.
So our conclusion is that baby 1 died from thrombosis and that there was no evidence of air embolism.
We get that bit, no evidence of air embolism.
Because in this baby, the allegation for air embolism was that number one, the baby died. We could not find a reason for it. Number two, this baby had this collapse accompanied by these skin discolorations, which was consistent with what the allegation was with air embolism. And what we are saying is, first of all, the second reason doesn't hold, because air embolism by the venous system does not produce these kinds of skin discolorations. Number two, there is a plausible and reasonable reason why this happened, which is what I just explained. So for both those reasons, we feel that this diagnosis is wrong, that this is not pulmonary air embolism. In fact, this is because of thrombosis.
So we feel that plausible explanation. There's no certainty here. It's a differential diagnosis, which is what doctors are supposed to do.
So now let's take a look at the expert panel. Now, Dr. Shu Li has assembled 14 experts from around the world, and this is from that specific report, the report for baby A. Take a listen to the following. The mother had antiphospholipid syndrome, which is a condition in which the immune system mistakenly creates antibodies that attack tissues in the body. These antibodies can trigger blood clots to form in arteries and veins. During pregnancy, antibodies can pass through the placenta to the neonate and lead to thromboembolism, particularly if there is concurrent infection. Post-mortem of baby 1 showed a recent non-occluding thrombus in the liver, which means there was a recent thrombotic event. On the day of collapse, baby 1 had 2 central catheters that were left without infusion for up to 4 hours, which predisposed to thrombosis when there is no infusion. Shortly after infusion was started in the most central line, baby 1 collapsed. A thrombus from the catheter tip likely migrated to an artery supplying the brainstem, causing sudden collapse and inability to resuscitate the infant. It is also possible that baby 1 had placental fetal vascular malperfusion, in which the fetal villi in the placenta present small thrombi that can travel to and occlude small blood vessels in major organs like the heart, brain and liver. If a small thrombus lands in the artery supplying a critical structure like the brainstem, it can cause sudden death, and they are very hard to find on post-mortem. Collapse associated with fetal vascular malperfusion can occur 1 to 2 days after birth.
Why did this baby suddenly collapse? So we went into the history of this baby to see what actually happened. So in this baby, the mother had antiphospholipid syndrome, which is a condition in which the immune system mistakenly creates antibodies that attack tissues in the own body. Now, these antibodies can trigger blood clots to form in arteries and veins.
Now, Professor Lee is simply stating the fact that APS can cause clotting in the mother. In the mother. At this stage, he's just referring to the mother.
And during pregnancy, these antibodies can pass through the placenta to the neonate.
Can pass.
And lead to thromboembolism, which means clotting in the baby.
So what's being stated here by Dr. Shu Li, and in particular during the press conference, is that this child died from a blood clot. Just trying to put it in the simplest terms as possible. This child died due to a blood clot. Now, the reason that this child developed a blood clot in the first place is a combination of the care that was given to this child, but also, and critically, most importantly, the fact that the mother had antiphospholipid syndrome. And that's the reason that this child was much more susceptible to getting a blood clot in the first place. Let's just read that again. The mother had antiphospholipid syndrome, which is a condition in which the immune system mistakenly creates antibodies. Remember this word, ladies and gentlemen, antibodies that attack tissues in the body. These antibodies can trigger blood clots to form in arteries and veins. During pregnancy, antibodies can pass through the placenta to the neonate and lead to thromboembolism, particularly if there is concurrent infection.
Now, Big Tam on Facebook, or Big Tam on YouTube, is all over the place here. He's focused in on one aspect, a singular aspect, which came later in Professor Lee's presentation, the antiphospholipid syndrome antibodies. And he's saying that Professor Lee is stating that we need these antiphospholipid antibodies to be present in the baby, otherwise we won't get the clot forming. Well, it doesn't really matter, if you think about it, whether the antiphospholipid antibodies were present or not, because we have the pathological finding of the clot. Something caused the clot. The antiphospholipid syndrome would predispose to that in a certain way, but we have the clot, and that's all that matters. And Professor Lee has put forward many reasons that could explain why the clot is there.
Now, what he hasn't told you, and the reason for the delay in my video today, is because I was waiting to receive the transcript from November 29th, 2022, and the evidence given in court by Professor Sally Kinsey. Now, let's just give you a little bit of a background into Professor Sally Kinsey. Now, Professor Sally Kinsey is a retired paediatric haematologist, a fellow of the Royal College of Physicians, the Royal College of Pathologists, and also an honorary member of the Royal College of Paediatrics and Child Health. She was a professor of haematology at Leeds University from 2007 and retired from everyday practice roughly 18 months or so before Lucy Letby's trial took place.
So, no doubt we're going to get very comprehensive, complete and impartial evidence from Professor Kinsey. And it's going to concentrate on her speciality of haematology and pathology, which is the accolades that he's just ascribed to her. Okay?
Professor Sally Kinsey gave evidence to the court on day 40 of Lucy Letby's trial. It was there that she gave expert evidence concerning the cases of child A and child B, and also regarding the case of child E. So let's take a look at what was established when Professor Sally Kinsey gave evidence. Okay, so if anyone wishes to validate what I'm about to share with you, this is day 40 of Lucy Letby's original trial, the 29th of the 11th, 2022, and again reading from the official court transcript. The following is Professor Sally Kinsey's evidence in chief, where she's asked questions by the prosecuting barrister, Nicholas Johnson, KC. I'm going to move on now, please, Professor, to your section 4 of your report. Within the medical records relating to child A, did you find the results of a full blood count test taken that had been undertaken on the 6th of July at just after 10 p.m? She replied, yes, I did.
Now, Big Tam is about to walk into a brick wall because he's told us that what Professor Kinsey looked at was a thing called a full blood count.
Just to put that into context for the jury, that's about an hour and 3/4 after he'd been born.
And to put that further into context, that means it was only valid at the time it was taken. Like the APGAR score, it's not really valid for much longer than the period of time for which you've measured it. Reassuring, yes, but does it give you any certainty about what you're dealing with? No.
She replies, yes. Others can ask you if it's thought to be necessary, but putting it in a sentence, was child A's full blood count normal or abnormal? She replied, it was normal of a child of his gestational age, yes. Thank you.
So it's very important that you note here the answer that was given to the question. It is normal for a child of his gestational age. Yes, thank you. Very specific to his gestational age.
The jury will recall from the evidence that a cause for concern in relation to both child A and child B was the maternal antiphospholipid syndrome from which the mother of child A and B suffered. She replied, yes. Professor Sally Kinsey then goes on to discuss in great detail what antiphospholipid syndrome is, and then is asked the following question. Did the antiphospholipid syndrome pass to either child A or to child B? She replied, no, that is not the case.
Now you have to understand that antiphospholipid syndrome in the mother is acquired during life. It's not a genetic disease and it cannot pass from mother to baby. But she has answered the question that she was asked.
I can explain that in a little bit more detail, because if one looked at the blood results, it would show that there were antiphospholipid antibodies in the circulation of the babies.
Now, the key part of this answer is if one looked at the blood. If one looked at the blood. Now, apparently we've already looked at the blood, but if one looked at the blood, one would find antibodies to antiphospholipid syndrome, or one may find antibodies to antiphospholipid syndrome.
The presiding judge, Mr. Justice Goss, then says, obviously it's very helpful of you to offer to do it, but the important thing is that neither child A or child B had this condition. She replied, that is correct. Yes, it is.
Now, I leave it up to you to decide whether the judge should have interrupted at this stage, because he's now left the jury thinking that the antiphospholipid syndrome cannot have any impact on this baby because it didn't pass from the mother to the baby, even though it can't pass from the mother to the baby.
Only the IgG, which is not significant in the children.
This is Professor Kinsey saying that the only antibodies that could pass into the child, if they did pass into the child, would be a class of antibodies called IgG. So there are different classes, IgG, IgE, IgM, and they're all based on the classification of their size, really, and how active that size enables them to become. But she says that if the IgG antibodies had passed into the baby, that they would not be significant. And Big Tam on YouTube is going to take her at her word.
Again, talking about the twins, child A and child B. Mr. Johnson. All right, we know from the evidence that we heard that the treating doctors at the time were concerned about this and were not sure that it hadn't passed. But you can say it didn't pass from mother to children. She replied, no, it didn't.
Now, you can clearly hear that what Professor Kinsey said is that the APS did not pass from mother to children. It didn't pass from mother to children.
Now, interestingly, this opinion of the expert here, and bearing in mind we're looking at a blood expert, a bona fide hematologist, this opinion appears to have been accepted not just by Lucy Letby herself, but also by her barrister Benjamin Myers KC, and also, you would imagine, Lucy Letby's experts from her original trial. Take a listen to the following. This is the cross-examination of Professor Sally Kinsey by Benjamin Myers KC. In that report, you go through the background relating to child A, as you have done in your evidence today. And at the end of the report, you can see at the bottom of page 7, you set out your summary and opinion, which goes over the page, in fact. She replied, yes. And your summary and opinion is focused on the question of whether or not there is any hematological abnormality, or whether maternal antiphospholipid syndrome played a part in what happened to child A. She replied, yes. And your conclusion in summary and opinion is that they didn't. She replied, yes. He responds, I am not disputing that. I am not disputing that.
Now, Big Tam thinks that this is really significant. The fact that Ben Myers is saying that he's not disputing that there isn't a hematological problem in the babies, in baby A or baby B. But it is irrelevant, really, whether there's a hematological problem in baby A or baby B. Because what is not stated here is that there is no consideration of immunological problems, electrolyte problems, and other problems that could contribute and would contribute to a clot. We have just said, or he has just agreed, that the APS itself did not contribute to the clot. So we'll accept that, and we'll look at the relative difference between the risk that baby A would have or could have created a clot if it had antiphospholipid passage and if it didn't have antiphospholipid passage.
Now, to your average member of the viewing public, this press conference would come across as incredibly compelling, particularly when Dr. Shu Li discusses air embolism. Now, during the press conference itself, Dr. Shu Li asserts that there is absolutely no evidence of venous air embolism. And this is due to the fact that any air injected into a child would need to pass through the lungs, where any air bubbles would be subsequently filtered out. However, what Dr. Shu Li doesn't tell the press conference or the wider public at large, is the fact that child A died with a patent foramen ovale, also known as a PFO. Take a listen to the following.
Now, I wasn't aware that Professor Lee had actually held 2 press conferences, but we'll just give you a requote of what he said at this press conference.
Now, in newborn babies, there's a hole called the foramen ovale in the heart, which can allow the blood to actually move over to the arterial system.
So this is the same press conference. This is what Professor Lee said. So let's just have a listen to that again to make sure that we're not deluded.
Now, in newborn babies, there's a hole called the foramen ovale in the heart, which can allow the blood to actually move over to the arterial system.
Now, Big Tam on YouTube is about to reach out to another guy to give us a GCSE level explanation of what a patent foramen ovale is, and hopefully to learn how to pronounce it.
Take a listen to the following.
A foramen ovale is a small hole between the 2 upper chambers of the heart called the atria. It's a small slit-like defect that occurs in utero in normal fetal cardiovascular development. And it allows for oxygenated blood to bypass the fetal lungs. Upon birth, after the first breath or so, that slit-like opening closes, except it persists and it does not close in about 25% of individuals. Typical healthy adult.
Now, I think it's really important that we hear that bit again.
Typical healthy adult.
And again.
Typical healthy adult.
So when a patent foramen ovale persists, it has no problem in typical healthy adults.
When it doesn't close, that hole, which we call foramen ovale, is then called a patent foramen ovale or an open foramen ovale. And in the vast majority of patients, 99.5% of individuals, that defect, the PFO, patent foramen ovale, has no clinical consequence, implication. It doesn't require study, surveillance, or management.
So in simple terms, this basically means that there is a small slit or opening in the heart. Now, this allows blood to travel between the right and left atrium, avoiding the lungs. Therefore, any air injected into a vein in a baby with a PFO would cause the symptoms this child experienced.
And an arterial air embolism, which was the purpose of the opening of the press conference with regards to baby A.
Now, we know that child A was born with, and as I say, most importantly, died with a PFO, an open foramen ovale, a patent foramen ovale. And this was discussed extensively during Professor Sally Kinsey's evidence. Now, I'm not going to go through the transcript in its entirety, but I will cover this in its entirety during a future live stream. But it's very, very clear, very, very evident, as I say, and important to remember that child A was born with and also died with a patent foramen ovale. And this is the importance of complete information.
And at this point, I would say that I have to agree with Big Tam on YouTube. The complete information is that with the patent foramen ovale, if the air moves from the emboli into or through the patent foramen ovale, it becomes paradoxically an arterial air embolism and is no longer a venous air embolism, and therefore everything that Professor Lee has said about venous air embolisms remains true. Being too fast and including too much information. for Big Tam to keep up with.
Dr. Lee's press conference assertion about air embolism failed to include crucial medical context. Child A's patent foramen ovale, also known, as I say, as a PFO, was a critical detail not mentioned during the press conference.
Now, in newborn babies, there's a hole called the foramen ovale in the heart, which can allow the blood to actually move over to the arterial system.
The presence of PFO creates a direct pathway that could allow air embolism to occur, contrary to the initial assertion. The omission of Child A's PFO in Dr. Shuley's press conference significantly alters the interpretation of the possibility of venous air embolism in this case.
Now, Big Tam, let's get this right so that you don't get your homework wrong the next time. If the blood is venous and the air is in the venous blood, it is a venous air embolism. If it's in the arterial system, it's an arterial air embolism. And if it happens to move from the venous system to the arterial system, it's a paradoxical air embolism, but is in effect an arterial air embolism, which means that Professor Lee's distinction between venous and arterial still holds true.
Now, this also makes me question good old Dickie Davis, good old David Davis, who by all accounts during this press conference claimed that he's read every single page of Lucy Letby's trial transcripts, including the evidence. So it makes me wonder why David Davis hasn't said this publicly. Why has David Davis not come out and said, well, hang on a minute, Dr. Shuley, you can't be right about this antiphospholipid syndrome because the child actually tested negative for antiphospholipid syndrome due to there being no antibodies in the blood test.
Oh dear, he hasn't heard the old expression, when you're in the hole, stop digging. So he keeps digging. And he now accuses David Davies of not knowing what he's talking about. Well, David Davies talks to people like Shuley. He doesn't listen to people like Big Tam on YouTube. And this is an ad hominem attack unworthy of a debate.
Oh, actually, Dr. Shuley, your assertion about venous air embolism and it being actually impossible isn't quite right because this child had a PFO. I wonder why he hasn't told anyone about that. Has he actually read these transcripts? I mean, not being funny, with the greatest of respect, I'm just a meager YouTuber.
No, a crap YouTuber.
But I mean, it's very evident when you read the actual evidence from this case and the trial transcripts that all of this stuff was dealt with during the original trial.
And if only it had been, sadly, though it wasn't. So we'll point out where all this went wrong during the evidence of Professor Kinsey and others.
Now, the Court of Appeal will simply laugh this out of the courtroom. If they try and put this forward as the real reason that Child A died, it just simply won't wash, will it? I mean, this has been accepted by Lucy Letby's defence, particularly the points regarding antiphospholipid syndrome.
So Big Tam is a legal expert as well. My God.
Now, it's also worth bearing in mind that this panel were tasked to find a different cause. They were tasked specifically to find something other than deliberate harm.
So I'll quote you from the press conference. Dr. Lee insisted that the panel findings would be published regardless of their conclusions, even if they bolstered the case against Letby. So it's entirely untrue to say that the purpose of this international panel was to exonerate Letby. The purpose of this international panel was to find the truth. Given what we've just heard this guy say, should we believe anything else that he said? I certainly wouldn't. I asked you, would you trust anything else he said? He just told a lie about what was the purpose of this international panel.
And if the best that they can come up with is antiphospholipid syndrome and a blood clot, and the fact that, well, really, air embolism wouldn't even be a possibility here, but failing to actually mention the PFO. I mean, if that's the best they can come up with as the most likely alternative other than deliberate harm, it really tells you quite a lot, doesn't it, about the defence case here?
It certainly does, because Baby A was probably the least that they could come up with, because it's the most mysterious and difficult case. When this guy, or if this guy, tries to work his way through the other cases, I don't know where the hell he's going to end up.
Finally, moving on to something else that wasn't discussed during this press conference in any way, shape or form in relation to Child A. The expert testimony of Dr. Owen Arthurs. Now, I've just purchased 500 pages of Dr. Owen Arthurs' evidence in court. Again, this will most likely be covered during a future live stream.
I will help you avoid having to listen to the 500 pages of Professor Owen Arthurs' evidence. In the case of Baby E, Professor Owen Arthurs gave the only circumstance in which X-rays, which were the only form of imagery or radiology used in this case, post-mortem X-rays, ante-mortem X-rays that were taken for different reasons, but he gave us, in the case of Baby E, the only X-ray that will prove clinically the presence of a venous air embolism, and that was that there would be large quantities of air in the chambers of the heart, as well as the great vessels, visible on an X-ray at the time of the actual incident, and that any other findings were consistent with, which is the evidentiary equivalent of living in the same street as a murder. Because you live in the same street as a murder, it's consistent with the murderer living in the same street. We can also say that the fever is consistent with every infection known to mankind. Not having a fever is also consistent with every infection known to mankind. So which is it? Fever? No fever? What evidence are you going to use? Because they're both consistently inconsistent, and they actually don't tell you whether you have an infection at all. It is impossible to infer causality from these X-rays alone. And it's unequivocally true to say that, because the X-rays lack what we call diagnostic specificity. They cannot distinguish gas from CPR and ventilation, decomposition or iatrogenic causes, example, the central lines, or indeed from deliberate harm. And they can't confirm that the air embolism and they cannot confirm the composition of the air embolism. And there's overlap in clinical context. In the Letby case, all the infants had contributing interventions, mechanical ventilation, central lines, and CPR. UK criminal standards insist that causation must be proven beyond reasonable doubt, or the link between the causation and the death has to be of a certainty, surety. X-rays alone can't meet this standard because there's no 3D localization, there's no gas composition analysis, and there's no temporal correlation. You don't know when this unusual line of gas actually went into the baby. So leading forensic analysis and leading forensic textbooks, Bizet, Bogdan, De Maio, the ones that everybody use to set the standards, what they say about X-rays is that gas on an X-ray is a non-specific finding, so therefore no causality. Autopsy correlation is essential before you make a conclusion, and that's incredibly difficult too. And you have to be able to distinguish iatrogenic causes or accidental causes from CPR lines, etc., from intentional causes. And isolated X-rays can't do that. They can't determine that. So a gas line in front of the spine could represent normal bowel gas, pneumometastainum, that's ventilator-induced injury, retroperitoneal area, that's air getting in during CPR, or air embolism that is either deliberate or accidental, or an artifact indeed. So the assertion that the X-ray alone cannot infer causality in these cases is absolutely true, and it really makes the contribution, in my opinion, of Professor Owen's evidence to this trial as next to useless. And when I say next to useless, I mean below useless. So let's see what else that he's leaving out that Professor Kinsey said during this trial. So when we look at the cross-examination by Benjamin Myers in the public record. So Benjamin Myers, KC for Letby's defence, is now asking Professor Kinsey questions. He says his questions are more concerned on the nature of air embolus. Mr. Myers asks about the principle of experts giving evidence and their areas of expertise. He refers to Professor Kinsey's expertise in haematology and certain paediatric specialisms and her reports. They include focus on cancers and blood disorders. Mr. Myers says, air embolism does not feature in your expertise, does it? Professor Kinsey says, no. Well, that begs the question straight away, why did Justice Goss not stop her giving evidence in areas that were not in her expertise? Mr. Myers refers to diagrams of gas exchange, which are standard images in the way gas exchange works in the body. And these are entirely irrelevant to preterm neonates because they haven't already developed the gas exchange mechanisms that she's showing to the jury. Mr. Myers goes on, in no way are they designed to explain an air embolism. And Professor Kinsey says they were produced to explain the gas exchange and circulation. Mr. Myers, what you are doing in your evidence is to take that fundamental understanding of circulation and gas exchange and use it to explain how an air embolism is displayed. Professor Kinsey says, yes. Mr. Myers says Professor Kinsey has at times commented on the issue of air embolism in her reports on baby A, B and E. And let's not forget now, these reports were written by Professor Kinsey when she knew the name Lucy Letby. Professor Kinsey goes, only in the changes to this colour of the skin. Very impactful. Mr. Myers refers to the summary opinion for baby A and whether there were any hematological significance for baby A. And she says, that is not in and he says that's not in dispute. Well, we're talking about hematological significance, not in dispute. But we'll deal with that in a minute. And he refers to the conclusion, which he says relies on comments from independent medical experts Dr. Dowie Evans and Dr. Sandy Bowen, and the description from Countess Chester Hospital consultant Dr. Ravi Jairam on the skin discoloration for baby A. Mr. Myers refers to the 1989 Medical Journal Review, mentioning a particular case, blanching and migrating areas of cutaneous pallor, etc. Professor Kinsey confirms she is drawing a parallel between the 1989 Journal Review and what had been observed by doctors and nurses. And I have to tell you that it was not observed by doctors and nurses, because if you don't write something down contemporaneously, it is not an observation. It's a recollection. It's a confabulation of what you thought you saw, but it is not a clinical observation. It does not meet that definition or criteria. But Sally Kinsey confirmed that she's drawing her parallels from that paper and these non-observed observations. She tells the court she was shocked by Dr. Jairam's description of skin discoloration for baby A, which she said came before she had considered the possibility of air embolus. She said she knew this is what air embolism was like and knew from her own education before seeing the description matched what was said in the 1989 Medical Journal Review. And Mr. Myers says Dr. Jairam's clinical note, legs noted to leg noted to look white and pale before cardiac arrest, does not contain the full details from her report. Dr. Jerem did not add anything further to skin discolour observations in the report to the coroner, Mr. Myers adds. Mr. Myers says the description you read came from a statement to police 2.5 years later, and Professor Kinsey agrees. Mr. Myers refers to the case of Baby B and the summary opinion Professor Kinsey made in her report. He says for her embolism, Professor Kinsey again draws parallels from the 1989 medical journal and the skin discoloration observations for Baby B. The clinical note of widespread purple discoloration with white patches for Baby B, made at the time, in other words an actual observation, is shown to the court, along with a subsequent improvement in skin perfusion. A doctor's note on June the 10th showed to the court sudden purple blotching all over the body. Upon my arrival, purple blotching later resolved. So, in other words, the clinician there at the time attributed discoloration of the skin to the lack of perfusion in the skin, which it is anyway. And they make that clear because they say in their observations that the purple discoloration resolved when the perfusion improved. Lucy Letby also noted on June the 10th, shown to the court, cyanosed in appearance, colour changed rapidly to purple blotchiness with white patches. So what does that mean? It means that there were parts of the skin that were deeply cyanotic, along with parts of the skin that had no circulation at all. That's what it means. Nothing more or nothing less. And Mr. Myers says, in none of those is there any description of bright pink or red features. And Professor Kinsey says, no. Professor Kinsey's report, dated November 1st, 2022, is referred to. So she knows who Lucy Letby is at that stage. Mr. Myers says Professor Kinsey was asked to give further explanation as to how an embolism worked. Now, why was a person who has no expertise in embolism asked to give further consideration as to how embolism worked? Again, you may as well ask Big Tam on Facebook. She says that she was asked to give further explanations on the features of her embolism. She said she was not an expert in such mechanisms, but she provided an explanation. So how much value has that explanation then? It has bugger all. Mr. Myers says the report notes that there is little medical literature in relation to her emboli, which is a load of crap. But anyway, Mr. Myers says you have used your knowledge of blood and circulation to assist this. Professor Kinsey says yes, and we're about to get an insight into her knowledge about blood and circulation, because Mr. Myers says part of the limited medical literature relates to decompression in deep-sea divers, colloquially known as the bends, and that in those circumstances, nitrogen bubbles would be in the circulation longer than oxygen bubbles. He asked Professor Kinsey if that is the case. And amazingly, Professor Kinsey says, I don't know the answer to that question. So the person that's writing these reports and telling the jury all about our embolisms and the impactfulness of them and the certainty of them and all the rest of them doesn't even bloody know if nitrogen stays in the blood longer than oxygen. Mr. Myers says the research paper in question for the bends dealt with 4 overweight deep-sea divers. And Professor Kinsey says, yes, there are many limitations to their findings. Mr. Myers asks if the symptoms of decompression sickness would result in skin discoloration, and Professor Kinsey said it would not. Mr. Myers asks if it can be applied to babies. If an embolus could always lead to skin discoloration observations, Professor Kinsey said it would not. Professor Kinsey says the problem with decompression syndrome in comparison to an embolus in infants is that the bubbles get bigger as the deep-sea divers return to the surface. Mr. Myers says that this is another limitation of the available medical literature for emboli. Professor Kinsey says
The reason that study was used in her report, that the overweight deep sea divers getting the bends, was used in her report to explain air emboli in preterm neonates. That's what she's saying. The reason it was used in her report was that skin discoloration had been an observation in that study, as it had been the cause of air embolism. But it wasn't the cause of air embolism. It was a cause of nitrogen gas embolism. So this is the kind of stuff that Professor Kinsey is going along with. Professor Kinsey says the scale of the air embolus problem would depend on the size of the air bubble and the type of vessels that it's in. It would also depend, Dr. Kinsey, on the dynamics and the physics of how the bubble works in the fluid. And to work that out, you would have to calculate its composition. And you would have to know how much of it was nitrogen and how much of it was oxygen, which you have just said you don't know. Upon a question from the judge, Professor Kinsey says she has never encountered any discussion about nitrogen bubbles in the system other than in deep sea divers. There you go. So the person who isn't an expert in air emboli wrote all these reports and knows nothing about nitrogen in the blood or oxygen in the blood, or the dynamics and physics of how all of this happens. So we'll do a podcast next week to blow this crap out of the water once and for all. But why was Professor Kinsey allowed to write reports and give evidence to a jury on a subject about which she admits herself she is not an expert? And she admits herself that she doesn't know the difference between the solubility of nitrogen and oxygen in blood. But this is the trial Lucy Letby went through. And this is what Big Tam here on YouTube doesn't get and will never get. Sally Kinsey also said, or this guy is quoting Sally Kinsey as saying that even if these IgG antibodies, APS antibodies passed into the baby, that they would always be harmless, that they're harmless. But again, that is not true.
So let's have a little look in more detail at these antiphospholipid antibodies. And we have to remember that we're talking very rare here. So again, it's a good example of why rare doesn't matter in that antiphospholipid syndrome and twin pregnancies are very rare. So that's going to limit what you do know about them, but it's not going to entirely eliminate what you know about them. And it is possible to infer generalities from these conditions, even though they're rare. So these are, as we said, passively, these antibodies, these IgG class of antibodies, are passively transferred from the mother to the baby, along with many other antibodies to any diseases, for instance, that the mother's had. And this is a physiological protection of the baby, this transfer. That's the mechanism by which the mother and the placenta can protect the baby from diseases. So in a way, the mother is passing over some kind of immune memory that the baby doesn't have. So the IgG antibodies for APS are no different in that regard to antibodies against measles, for instance. Now, Big Tam on YouTube has all of these pages of evidence where Sally Kinsey talked endlessly about IgG antibodies and APS, but I'll just tell you some of the things that she should have said in the evidence that he didn't read out. And he doesn't read them out, I suspect, because it's really boring, this stuff, set beside Lucy Letby's WhatsApp messages. But it's critical, nonetheless, to understanding how she was stitched up by what some of these experts said. So the limits that are put on the transfer of these antibodies include gestational age, for instance. So at 30 weeks, these babies would have, if they're transferring these antibodies, they would have about half of what's present in the mother's blood in exactly the same profile. And when I say profile, I mean the types of antibodies, because we're actually talking 3 types of antibodies specifically for APS that are associated with clot formation. So not just 1, 3. And because they need to have a receptor on the fetal side, a mechanism that enables the passive transfer to take place, that can become saturated, and that would put a limit on how much of the antiphospholipid antibodies could transfer. And there are subclasses of these antibodies. So IgG 1, 2, 3, 4, 5, and these will have different profiles of efficiency and how they transfer. So that's going to limit how they get over the placenta. And indeed, the integrity of the placenta itself is going to put a limit on these things. So the main thing here is that Sally Kinsey said that even if the IgG antibodies had crossed the placenta, they would be essentially benign, that they wouldn't harm the baby. And while that is probably generally true, it is not absolutely true. They can cause death in these babies on their own. A perfectly healthy baby, unlike baby A, can get passive transfer of these antiphospholipid antibodies, which will kill them. And there are documented cases where that has happened. So that's the first thing we should correct, that an expert should say. These are not always benign. But really, most of the research focuses on what's called the second hit hypothesis. And that is what is reflected in the actual practice, that it's usually in the presence of other complications that you see these antibodies have an effect. And that would be prenatal complications like preeclampsia, that's high blood pressure and stuff in pregnancy, tick for baby A, intrauterine growth restriction, tick for baby A, birth asphyxia and sepsis, tick for baby A, and iatrogenic factors such as arterial and venous catheterizations, tick for baby A. So if you are going to look for these antibodies in the baby, would you always find them even if they were there? And the answer to that is no, you don't always find them even though they're there. And the baby can make them themselves. They're called de novo. But oddly enough, research shows that as the level of antibodies rise in the mother, they paradoxically fall in the neonate. And during the formation of the clot in the baby, that's our portal vein clot, which is the only solid evidence for anything that we have in this case, that process of clot formation can consume the antibodies that have already been transferred. So you might find evidence of them in the clot, but you won't find evidence of them in the blood. And that's called a false negative finding. So the medical condition of the baby, the second hit phenomena, has consumed the antibodies that were transferred. And you need a specialized laboratory, which the Countess of Chester Hospital wasn't, which means that the blood test taken at 1.5 hours or 1 3/4 hours could not detect. It would not have been sent for detection of these antibodies. But even if it was, so first of all, we'll look at the cross-examination of Sally Kinsey by Ben Myers from the public record, not by buying 500 pages or 5,000 pages of empty words, but what a good journalist thought was worthy of writing down. So Ben Myers, testee for Lucy Letby's defence, is now asking Professor Kinsey questions. He says his questions are more concerned on the nature of error embolus. Mr. Myers asked about the principle of experts giving evidence and their areas of expertise. He refers to Professor Kinsey's expertise in hematology and certain pediatric specialisms and her reports. They include focus on cancers and blood disorders. Mr. Myers says that error embolism does not feature in your expertise, does it? Professor Kinsey says no. So why is Professor Kinsey giving evidence, expert evidence, on error embolism when in the very first question she's just said that she is not an expert on error embolism? And what's more, she's about to demonstrate why she's not an expert on error embolism. So Mr. Myers refers to the diagrams of gas exchange, which are standard images in the way gas exchange works in the body. So straight away, that's not going to apply to a preterm neonate because the biggest problem they have is that their gas exchange isn't working. But let's carry on. Mr. Myers, in no way are they designed to explain error embolism. Professor Kinsey, they were produced to explain the gas exchange and circulation. Mr. Myers, what you are doing in your evidence is to take that understanding of circulation and gas exchange and use it to explain how error embolism is displayed. And Professor Kinsey says yes. And Mr. Myers says Professor Kinsey has, at times, commented on the issue of air embolism in her reports for babies A, B, and D. And Professor Kinsey says, remarkably, only in the changes to the colour of the skin. Very impactful. So we now have Professor Kinsey acting as a non-expert in embolism, but as an expert in dermatology as well. Mr. Myers refers to the summary opinion for BBA and whether there was any hematological significance for BBA. He says that is not in dispute. Now, Big Tam on YouTube thinks this is a big deal, but it isn't a big deal at all. Keyword is hematological. And then Myers carries on. He refers to the conclusion, which he says relies on comments from medical experts Dowie Evans and Sandy Bowen, and the description from the Countess of Chester Hospital consultant, Dr. Ravi Jairam, of the skin discoloration for BBA. Mr. Myers refers to the 1989 Medical Journal review mentioning a particular case, blanching the migrating areas of cutaneous pallor were noted in several areas, and in one of our own cases, we noted bright pink patches against a generally cyanode background. And Professor Kinsey confirms that she is drawing a parallel between the 1989 journal review and what had been observed by doctors and nurses. So Professor Kinsey, who's not an expert in air embolism, is confirming that she's not an expert in air embolism because she's about to draw parallels from a paper that discussed pulmonary vascular air embolism and apply it to a completely different classification of disease called venous air embolism. She tells the court she was shocked by Dr. Jairam's description of skin discoloration for BBA, which she said came before she had considered the possibility of air embolism. Now, I read that the way it's written. It came before. The description of Dr. Jairam came before she had considered the possibility of an air embolism. Now, at this stage, we have to understand that when Professor Kinsey was writing her report, she knew who Letby was, and she knew what Letby was in the frame for. She knew what Dowie Evans' theories were. She knew what Dr. Jairam's theories were. But she is shocked by his description, which came before she had considered the possibility of air embolism herself. She said she knew what air embolus was like and knew from her own education before seeing the description match what was said in the 1989 Medical Journal review. Mr. Myers says Dr. Jairam's clinical note, legs noted to look very white and pale before cardiac arrest, does not contain the full details from her report. Dr. Jairam did not add anything further to the skin discoloration observation in the report to the coroner, Mr. Myers asked. Myers said the description you read came from his statement to police 2.5 years later, and Professor Kinsey agreed. Now, as we'll explain in the next podcast, Dr. Jairam did not witness the arrest of baby A. So even this description which he gives, legs noted to look very white and pale before cardiac arrest, was the description that the attending physician, Dr. Harkness, gave him after the baby had collapsed and was undergoing CPR. But we'll deal with that in the next podcast. So we have Dr. Kinsey here giving evidence as a non-expert about clinical observations that were not actually observations. In medicine, an observation is what you write contemporaneously. You have to write it at the time, otherwise it is not an observation. At best, it's a recollection, and at worst, it's an invention. And if you go to any lawyer, medical legal lawyer, and you ask him, can you make up stuff to defend yourself against a malfeasance lawsuit? He will tell you, if you didn't write it down at the time, it didn't happen. But it seems in this case that only applies to the lower standard court, the civil court, and not to a murder trial. And Mr. Myers refers to a case of baby B and the summary opinion Professor Kinsey made in her report. He says for air embolism, Professor Kinsey again draws parallels from the 1989 Medical Journal and the skin discoloration observations for baby B, the clinical note of widespread purple discoloration and white patches for baby B led at the time contemporaneous note is shown to the court along with subsequent improvement in skin perfusion. So, ladies and gentlemen, very important to read this bit right. The attending physician noticed widespread purple discoloration and white patches, which disappeared with skin reperfusion. Therefore, what that doctor was describing was mottling. But Dr. Kinsey has inferred it as being due to an neuroembolism. And Mr. Myers says, in none of those is there any description of bright pink or red features. And Professor Kinsey says, no. And Professor Kinsey's report is dated November 1st, 2022, when Lucy Letby was in prison. And then bizarrely, Mr. Myers says Professor Kinsey was asked to give further consideration as to how a neuroembolism worked. Now, he doesn't say asked by whom, but we can guess. But she's already admitted that she's not an expert on neuroembolism, so why would they ask her for more reports? And then this goes back and forth, not really saying something, and we've covered it before. And the crucial bit is that Mr. Myers says of the limited medical literature that relates to decompression and deep sea divers, colloquially known as the bends. I don't know how the hell we got here, but and that in those circumstances, nitrogen bubbles would be in the circulation longer than oxygen bubbles. He asked Professor Kinsey if that is the case. So he's asking Professor Kinsey, a non-expert on neuroembolism, masquerading as an expert on neuroembolism, does she know which gas, nitrogen or oxygen, is more soluble in blood, which is an undergraduate question. And Professor Kinsey's answer is, I don't know the answer to that question. And we will explain in the next podcast why that is so telling.
Risk of clot formation by 141 times. And 4 hours without fluid will definitely cause dehydration in a 30-week preterm baby. We have 2 central lines here, and we have a clinical diagnosis for sepsis. So we have 141 times elevated risk for clot. If we only had the finding of antiphospholipid antibodies in the mother, that would raise the odds of a clot by 2.3 times. So baby A, 142 times, just antibodies on their own in the mother and no complications in the baby, 2.3 times. And the finding of the antibodies in the baby alone with no other complications, risk elevation 8.2 times. So we can clearly see in the pathological process that's going on in baby A, the central line, the sepsis, and the dehydration are by far the biggest risks for clot formation, independent of the effects of the antiphospholipid syndrome in the mother or in the baby, which is why Ben Myers had no problem accepting that assertion when he said to Sally Kinsey, we don't dispute that. We don't dispute that. It's just a pity that he didn't point out the relative risk difference. The treatment that this baby received in the Countess of Chester Hospital, along with the sepsis, elevated the risk for clotting by 142 times over baseline, compared to 8 times over baseline for the finding of the antibodies in the baby alone. So Big Tam on YouTube is talking crap. The Court of Appeal, if they were serious about justice in the UK, would want to know why this wasn't told to the jury. And they won't laugh it out of court. They should consider that they too, as judges, have been duped, because they can only make judgments on the facts in front of them. So, as I say, a very long podcast. I'll leave a link to this essay that I did to synthesize all of this stuff. Now, people are going to argue with it, and that's fine. But if they do argue with it, they have to produce their own model and point out why my model that claims that the treatment was the cause of the clot, which was also the cause of the transfer of the clot across the patent foraminal valley into the brain of the baby, as Professor Lee said, was the true cause of death in baby A. So we'll see you in the next episode where we're going to look at the so-called pink flooding rash. And we're going to use physics and we're going to use fluid dynamics and different scenarios to prove conclusively that Dr. Jairam could not have seen what he thinks he saw. So we'll see you in the next episode. Bye.